Hello, I'm Dr. Tejal Gandhi, Chief Quality and Safety Officer at Partners Healthcare, and I'm going to be talking to you today about health information technology and how it can potentially benefit patient safety. The objectives for this session are to describe health information technology, or HIT innovations, and their impact on patient safety, and highlight strategies for success when designing HIT initiatives. HIT and patient safety can be put into three categories. There's technology to facilitate clinical decision-making and reduce reliance on vigilance and memory. There's technology to facilitate system-clinician communication, and technology to facilitate provider-to-provider and provider-to-patient communication. And I will give examples of technologies in each of these categories. So first is technology to facilitate clinical decision-making and reduce reliance on vigilance and memory. And I'm going to talk predominantly about medication safety. So this is an example of a physician order that was handwritten. Try to guess what the drug is that this order is trying to communicate. Most people guess Coumadin. The answer actually is that this prescription was for Avandia. And it just highlights the fact that handwriting can lead to errors due to inability to tell the drug or the dose or the frequency. The next slide shows a different type of issue, which is in the intensive care unit, the number of pieces of equipment, types of medications, numbers of lines and tubes that need to be managed, all could contribute to an increased risk for error. When you think about medication safety, the typical hospital medication process has several steps. There's ordering, where the physician or ordering provider orders a medication. Transcribing, a nurse copies the order onto a paper medication administration record, or MAR. That sometimes is often, it can even be done by a non-nurse. There's dispensing, pharmacy sends the medication to the floor, and there's administering. The nurse gives the medication to the patient and documents this on the MAR. Medication errors in hospitals are common and can have serious consequences and can occur at any of those stages. Here's a flow diagram that depicts the same sequence where the physician orders, the pharmacist dispenses, the nurse administers. And you can see that the percent of errors in each of these stages is displayed here, where ordering errors account for about half of the errors that you see. Administration errors about a quarter, followed by dispensing and transcription. This is based on a study in the 1990s. So, what are the main strategies for preventing errors using IT? IT can provide tools to improve communication, can make knowledge more readily accessible, can require key pieces of information, assist with calculations, perform checks in real time, assist with monitoring, and provide additional decision support. So those are all the ways that IT can actually prevent errors. In terms of potential IT solutions, computerized physician order entry is the one that's probably been studied the most and talked about the most, and that really tackles the issue of ordering errors. So it is a computerized writing of orders, and one study showed that there was a 55% reduction in serious medication errors after implementation of CPOE. Barcoding, electronic medication administration records, and smart pumps are technologies that have the potential to tackle transcription, dispensing, and administration errors. And we'll talk about that a little bit later. But going back to CPOE, CPOE can streamline and structure the process of ordering. Doses can be picked from menus, there can be decreased transcription, and complete orders can be required. It also gives information at the time needed, such as showing relevant laboratories. If you're ordering a drug that is renally cleared, CPOE can show you the creatinine right at the moment where you need to know it. There can be guidelines and guided dose algorithms, and then all sorts of checks that can be performed in the background. Here are some screens of a typical CPOE system where this kind of decision support displays alerts to the providers. And another example, particularly useful in chemotherapy, because there can often be daily dose limits, lifetime dose limits, etc., and the computer can help calculate those. So as I mentioned, CPOE has been shown to reduce all medication errors by 80% and serious medication errors by 55%. An issue with CPOE is the issue of alert overrides. Studies have shown that physicians override clinical decision support alerts a large percentage of the time. And you can see in these studies here, the vast majority of alerts actually were overridden. In addition, over-alerting has led to major boycotts of CPOE systems. There are some potential strategies to improve alerting. For example, creating streamlined knowledge bases that only show essential content or only alert for essential content. And there's certainly a balance between sensitivity and specificity, but if you alert less, people will pay more attention to the alerts that they do receive. Tiering of alerts is also a possibility, maybe displaying the really important alerts in a different way than the ones that are just sort of an FYI. And the goal really is to minimize interruptions. In one study done in an electronic medical record, when streamlining and tiering were implemented, 67% of alerts were accepted versus 20% from most other studies. So streamlined knowledge bases and tiered alerting have higher acceptance rates, especially for very high-risk alerts, and more work really needs to be done to maximize the clinical benefits of alerts and figure out what the ideal acceptance rate is, what is the best way to display alerts, etc. The sharing of streamlined knowledge also should be widespread. There's no need to reinvent the wheel where every hospital has to come up with its own streamlined version of the knowledge base. So moving from ordering to dispensing errors. Dispensing errors are relatively common in hospital pharmacies, really because of the high volume of medications dispensed. In one study of a 700-bed academic medical center, there were 6 million doses per year dispensed, and they found 44,000 errors per year. Many dispensing errors have the potential for harm, and only 1/3 of the serious errors are intercepted prior to administration. So one intervention to prevent dispensing errors can be pharmacy barcoding. With pharmacy barcoding, pharmacy technicians use barcode scanning to verify that the drug they are dispensing matches the physician's orders. In one study, the impact of pharmacy barcoding was evaluated, and you can see that the dispensing error rate dropped by 31%, and the errors with potential for harm, or potential ADEs, that rate dropped by 63%. In addition, if you looked at target potential adverse drug events, such as wrong medication, wrong dose strength, or wrong dose form, you can see the reductions in the various types of errors. So this study had a projected impact at the study hospital of preventing per year over 13,000 medication dispensing errors and over 6,000 errors with potential for harm. In addition, a cost-benefit analysis was performed, and they found that there was a break-even point within the first year after go-live with a 5-year cumulative net benefit of over $3 million. And most of that benefit came from adverse drug events that were prevented. After CPOE and pharmacy barcoding, the most common error type found in the study I showed in the beginning was administration errors. So barcoding and EMR at the bedside are thought to be the best intervention to prevent those dispensing and administration errors. With barcoding and EMR, orders flow electronically from CPOE to an electronic medication administration record, or an EMR. This eliminates transcription entirely. And nurses have laptops with EMR, and they use this to track what medications need to be given or administered. And nurses use barcode scanning of the medication and the patient to verify that the drug they are administering matches the physician's orders. Right drug, right patient, right dose, and right time can all be checked with the barcode scanning, and the EMR alerts if any of these is incorrect. In the system that was implemented at Brigham and Women's Hospital, they use this type of technology. As I mentioned, the nurses were using laptops. They also had scanners that could scan both 1- and 2-dimensional barcodes and were wireless, Bluetooth compatible, so they could sync up with the laptop. Here are some screens of the EMR, and you can see that it has a report for the nurse that shows which medications are overdue for a patient, which ones medications are due, and other medications that the nurse has to be aware of. There's an example of a wrong medication alert and an example of a wrong patient alert, again with the wristband scanning. We did a study to look at the impact of barcode and EMR on administration errors and found a 41% reduction in medication administration errors and an over 50% reduction in errors with potential for harm. In addition, with nurse surveys, we found that nurses feel medication administration is safer and more efficient after implementation of barcode technology. And we also looked at nursing workflow. Again, in this one site that implemented EMR and barcoding, we found the proportion of time spent on medication administration did not change after barcode EMR implementation, but the proportion of time spent in the presence of the patient increased. So in summary, barcode technology significantly reduces dispensing, transcription, and administration errors. And in the hospital pharmacy, at least, the benefits of the technology outweigh its costs. A well-designed and fully supported system did not increase the proportion of time nurses spend on medication administration and did not compromise the amount of time nurses spend with patients. For us, the key to this implementation was involvement of end users from the beginning in design, hardware selection, and piloting. So if we go back to our flow diagram, in red are shown the percentage of errors in each of these stages, and then in teal you can see the impact of these various IT interventions on these error stages. So again, order entry reduces those ordering errors by about half. Pharmacy barcoding can reduce dispensing errors by almost 2/3. EMR barcoding, another 50% reduction. And EMR reduces transcription errors entirely. So with these kinds of technologies, significant impact can be made on serious medication errors. Moving into the outpatient setting, we know that adverse drug events are common in the outpatient setting. In this one study, 25% of primary care patients had an adverse drug event. In addition, prescribing errors are also common. In this one study, looking at over almost 2,000 prescriptions, about 8% of prescriptions had a medication error. When looking at those errors, more advanced computer prescribing checks with decision support would have prevented 95% of the errors with potential for harm. And the majority of the prevention would have come from complete prescriptions, drug dose checking, and drug frequency checking. So, more recently, studies have come out showing the potential impact of electronic prescribing or e-prescribing on those kinds of errors. One study of 15 providers before and after implementation found that error rates reduced from 42 per 100 prescriptions, a very high starting rate, to 6 per 100 prescriptions. Another study, again a pre-post study, found that prescription errors decreased from 18% to 8% after implementation of e-prescribing. HIT can also be a powerful tool to help with medication reconciliation. We designed a tool to display patients' home medications electronically, pulled from the electronic medical record and pulled from prior discharge summaries. And in our hospitals, residents use that information to create a pre-admission medication list and subsequent admission orders. So we call this tool the PAML Builder, Pre-Admission Medication List Builder. And on the left, medications from electronic sources like the EMR or discharge summaries get collated, and then the admitting physician can click on which medications the patient is truly taking to create the pre-admission medication list, but it gives them a nice starting point. Then they can also implement the input the planned action on admission, and that action, if it is continue for the hospitalization, then leads to an inpatient order in the CPOE system. Here's an example of that planned action on admission. In addition, that pre-admission medication list can be displayed at discharge. So the pre-admission meds are displayed with the current inpatient medications, and the provider can perform reconciliation to create the final discharge medication list. This can also be used for patient education, since it makes it easier to tell the patient what medications are new, what has changed, and what stayed the same from their pre-admission list. In one study, this tool demonstrated a 55% reduction in medication discrepancies with potential for harm. We built a similar application for post-discharge medication reconciliation that displays hospital discharge medications side by side with electronic medical record meds. The impact of that tool is being studied, but here's a screen from that, and you can imagine a primary care physician who on the left sees what the electronic medical record shows, on the right sees what the discharge medications are, and they use that to reconcile that outpatient list. Now I'm going to move on to technology to facilitate system-clinician communication, and I'm going to focus on alerting of test results. So one example of system provider communication around lab alerting is a project that was done to improve response to critical lab results. And this project developed a general application called an event monitor that sifted through data to find events of interest, such as critical lab results, and alerted the provider via order entry and auto-paging of the fact that there was a critical result that was back. And here's the screen that would pop up for the provider who ordered the test, and it might be something like a falling hematocrit. And it would allow the provider to see this result had come back and order perhaps additional laboratories or order additional medications in response to that result. This system was studied and was found to decrease time until treatment was ordered by 38% and decrease the time until the condition resolved. Physicians also seemed to like it and use it, and it became an accepted part of practice. Another example is an outpatient test result manager with the goal of improving outpatient follow-up of test results. Before we started this project, we surveyed our attending primary care doctors and found that 57% reported not being satisfied with the way they managed test results. This created an opportunity to implement a change. So we created an outpatient results manager in the electronic medical record that allows review of all chemistry, hematology, radiology, and pathology results ordered by a clinician with abnormal and critical results highlighted. Those results can be forwarded to other clinicians. It allows users to document electronically that results have been reviewed and generate result letters for patients with a few mouse clicks. Also, it gives the ability to set ticklers and reminders for tasks in the future. And here's an example of a screen from that application. You can see that you can view results. Alerts and guidelines related to the result can be accessed easily. Ticklers can be created. Patient documentation such as letters, etc., can be performed. So this tool was studied to see what its impact on patient satisfaction was, and a randomized control trial was done, and intervention practices are in pink, and you can see that patients in the intervention practices had a significant improvement post-implementation of the results manager in terms of their satisfaction with test result communication and their satisfaction with information given about the treatment and condition. Another interesting example of communicating test results is a tool known as Anchor that was developed at Brigham and Women's Hospital. This is a tool that allows radiologists to set flags for radiology results. So a radiology result can be flagged as a red alert, potentially life-threatening, orange, needs urgent action, or yellow, something that's not requiring urgent action but needs some kind of follow-up. The ordering or referring provider then for red and orange alerts gets a page that they have a critical radiology result and to please call the radiologist back. But for yellow alerts, they receive an email with a link to the result embedded in the email. And here you can see that when they click on that email link, they can see the alert and then they can acknowledge that they have viewed it. All unacknowledged alerts are visible on the Anchor dashboard for both the ordering or referring doctor as well as the radiologist. So if red and orange alerts are not acknowledged, the radiologist is automatically notified. And if yellow alerts are not acknowledged, the radiologist and referring doctor get daily email reminders. This is particularly useful for these yellow alerts. Most hospitals do a very good job on the reds and oranges, but most hospitals do not have a way to close the loop on those yellow alerts, such as a pulmonary nodule that needs follow-up, in terms of knowing that the ordering provider has seen it and acknowledged it. And those are the kinds of results that fall through the cracks in the outpatient setting, leading to missed and delayed diagnosis. Another interesting example of system provider communication relates to tests that are pending at the time of discharge. One study showed that 41% of patients had test results return after discharge. Of these, 9% were potentially actionable, but physicians were unaware of 2/3 of these results. An intervention using HIT was developed to try to solve the problem of pending tests at discharge. And in this intervention, an automatic email notification was created when a test result returned after hospital discharge and notified both the hospitalist physician and the primary care provider of the result of that test. So in this example, a microbiology notification was sent that a blood culture had turned positive after discharge. One study that looked at the impact of this kind of email notification of pending results found that in the intervention group that received these emails, 72% of physicians were aware of the result of that pending test, compared to only 34% in the control group that were aware of the result. In addition, physicians were very satisfied with that automated notification system. Finally, I'm going to move on to technology to facilitate provider-provider and provider-patient communication, and I'm going to talk about handoffs and electronic health records. So in terms of provider-provider communication, sign-out is what is normally called when providers hand off coverage between each other. And a study was done at Brigham and Women's Hospital that demonstrated that there were more errors when a patient was taken care of by covering physicians than by physicians who were sleep deprived. And reducing physician work hours, as we know, does increase handoffs. So the goal with the sign-out tool is to design a system to standardize the communication and access to patient information and improve handoffs to covering physicians. A sign-out application can be used when a physician goes home, and a coverage list application creates a list of patients for the physician. The computer compiles relevant data for the patient. The physician adds some textual data and a to-do list, and the report is printed and given to the covering physician. Here's an example where the problem list and the laboratory results, the code status, etc., are automatically populated. The provider puts in this general status piece as well as the to-dos for the evening. This kind of system standardizes the communication process and emphasizes a safety culture of teamwork. And a study was done of this particular sign-out tool that showed a trend in reduction of preventable adverse drug events. After sign-out was implemented, the sign-out tool was implemented, the risk of an adverse event during cross-coverage became no different than during regular coverage. Another type of tool to improve teamwork and provider-provider communication is an application that we've developed at Partners called Responding Clinician. And the goal here is to create a responding clinician in the computer that is an easy identifiable doctor, so that the nurse at 2 in the morning knows exactly who to page. And we found that 50% of patients prior to implementation of this system did not have an easily identifiable responding clinician, especially on nights and weekends. And this is particularly an issue in hospitals that are teaching hospitals and where the residents now have an increasing number of handoffs, so it can often be challenging to know which resident is responding at any particular time. We've had examples, as you can see from this screenshot, of when you go to the pager system for a particular physician, you can see that there's a long list of details of who can be reached for what particular situation. And the nurse kind of has to go through all of these scenarios to figure out who the right pager is for which issue. So the solution that was developed was that clinicians would own the responding clinician relationship, and it would be tied to both sign-out and beeper changes. So when they're doing their sign-out at the end of the day, they also have to reassign the patient to a new responding clinician. Order entry will prompt the clinician if the responding clinician data is missing or old, or the patient's been transferred to a new service, to prompt them to update that information. And the pager cannot be out of hospital unless the clinician is no longer a responding clinician. And compliance reports get shared with the department chiefs. So, for example, in this screen, you can see a particular person's patient list, and they can, when they sign out, reallocate all those patients to a new responding clinician. In addition, for the nurses, we have a screen on something called a pod monitor. This is where the nurses on the floors can look and see which patients are on the floor, and there's a responding clinician column where they can easily identify who the responding clinician is at that moment. Now, another way to improve provider-provider communication is a relatively simple tool, email notifications. And this is something that's been implemented at our hospitals to automatically email primary care providers when a patient is seen in the emergency room, is scheduled for surgery, has surgery, is admitted or readmitted to the hospital, or discharged. And we're now adding automatic emails to discharging attendings when patients are readmitted. And this is just a relatively simple way to ensure that communication is going on between the hospital and primary care provider about things that are happening to their patients. So, moving on to electronic health records. We've already reviewed some of the safety benefits, such as e-prescribing and test result management. But there's other benefits as well, such as legible available notes, visit summaries for patients, information access, alerts and reminders, and communication. One example relates to referral communication. So, in one study, 65% of primary care providers and 35% of specialists were dissatisfied with the referral process due to lack of timeliness of communication, lack of clarity of communication, and the time required to create referral documentation. In the electronic medical record, we created a referral tool that would make it quick and easy for a primary care doctor to send a referral note to a specialist. The electronic referral communication module facilitated information from the primary provider to the specialist and was studied at 2 sites. And sites in the intervention site, specialists were more likely to receive communication. PCPs more often received return communication, which was not part of the electronic tool, but it just seemed that if specialists received communication, they were more likely to then send something back. And patients were more likely to report that the specialist had seen information before the visit. So we really need to optimize these kinds of tools within electronic medical records. In addition, HIT can be useful for patient-doctor communication. And the big player here is patient portals. Here's an example of the Partners patient portal known as Patient Gateway. In Patient Gateway, patients can request prescriptions, appointments, and referrals. They also can start to help with medication reconciliation. For example, reviewing their medication lists and talking about patient adherence. Is the patient still taking the medication? Are they having side effects, etc.? And these are the kinds of things that a patient portal can help capture prior to a visit and hopefully facilitate conversations about medications and adherence during the visit. So we created a tool in the patient portal to facilitate those kinds of medication conversations, and then in the electronic medical record, this information popped up for the provider so that the PCP could look at the information and update the medication list if a patient was no longer taking a medication, but also hopefully start having conversations about adherence and noncompliance. Those are all examples of tools that can improve physician-physician communication and physician-patient communication. I think key elements for HIT success, when I think back through all the interventions that I've just talked about, are that senior leadership needs to support IT resources for patient safety, and it's really important to emphasize safety benefits and tell stories, as well as use data to show why these tools are going to have benefit. Second, it's really important to have clinical staff championing this to support the use of this technology. You need to measure and demonstrate benefit, but also engage the clinical users in the design process and get their feedback in whatever way necessary to make sure the tool is going to really meet their needs. Understanding workflow and speed is essential, and during rollouts, again, it's important to emphasize the safety benefits above all else. Be ready to uncover unknown processes that have been supporting the existing process. Other key elements for HIT success: avoid over-engineering, try to keep it simple. Implement well. 24/7 support and super users are often needed in the first few weeks of implementation, and training can be most successful when clinicians teach clinicians. As I mentioned before, measure impact. That feedback back to the frontline staff is really important, and continually seek user feedback for improvements as well. This can be through electronic feedback, through face-to-face focus groups, looking at why clinicians override things. All of those things can be used to make improvement. And the work really never ends. Brigham and Women's implemented physician order entry in 1994 and still continues to make improvements to it. So that's just, I think, something that people need to acknowledge and realize that any HIT tool will hopefully reduce errors, but may also lead to new problems that then need to be resolved and improved upon, etc. So in summary, both non-technology and technology solutions are important for improving, patient safety. Creating a culture of safety and ensuring action based on events identified is critical, but technology can provide the high reliability infrastructure to reduce human error. And HIT can have a large impact on physician decision-making and improved communication between systems, providers, and patients. And studying the impact of these interventions is essential for future adoption. And hopefully this last cartoon will become reality, where the doctor's orders will only be seen handwritten in museums. So thank you very much for your time, and I hope you found this talk helpful.